Oh, just type here when you're here. I know some people are driving, so just be careful, please. Whose iPhone Pro 11 poop emoji?
That's just you guys.
Someone is a poop emoji.
Hey, Lando, I'm driving, so I can't text, but I'm here. Hey, Lando,
Who just said that?
Raimi.
Lainey, okay. You're fine. Yes, no, please be careful. I know this isn't ideal. Are you guys going to be always driving or?
So I was taking it out of there, Jim said, "Oh my God!"
Oh guys, please be careful. What is that?
I'll be driving every Friday when we have this.
Well, I guess, you know what? I am recording this. So for you to take notes, you can always replay it. So you can go home to your notes and write stuff in. So if that's happening for people, you're at least hearing me. And that's better. Because are you guys always going to be at school on Fridays for one of your other classes? I guess you are. Okay. Half of you. Okay. I'm hearing all the road. Everyone be careful. Okay. So Mackenzie Morgan, you're the poop emoji. Okay. All right. Let me get the notes pulled up. It's good to see some of you in person. Okay, so Joy's coming. Okay, that's fine. Hang on, my PowerPoint's being stupid. Hopefully my internet cooperates. It's been a little iffy too, so we'll see what my internet wants to let me do today. Did anyone have any verbal questions on the homework? I have to look at it. I haven't had time to look at the discussion board yet. For the homework.
16.
Huh?
Number 16.
Number 16. Does someone want to remind me what that says? I got to pull up the homework. Does anyone know 16? Let me see if I can pull. Hang on. It's going to take me a second to pull it up because my, okay. Not on top of Zoom. What is unique about brachycephalic and recovery? So the main thing I was looking for there is that normally I will always wait for a patient to swallow 3 times, and then I usually pull the tube. Once they can usually swallow 3 times, we're typically okay to pull the tube. The issue being that brachycephalics, sometimes I have them almost sitting up and standing with a tube in. So because they are prone to airway collapse, you want to make sure they're very, very awake. So that is what's unique. You're going to have to probably take a little bit longer to extubate them. That's the difference. The other thing I want to bring up, What is, for number 12, it says, what is the first thing we do after pulling the tube, and what do we do before turning the patient? I'm sorry that that was kind of a vague question on my part. What I'm looking for is, as soon as you pull the tube, you want to observe respiration and take a respiratory rate, because you've just removed their airway. Okay. Okay. You want to maintain, when you have a tube in, they have an airway. I'm going to mute everybody just while I'm talking. Okay, because I kind of feel like I was trying to shout over the noise. When they have a tube, they have an airway present. When you pull the tube, a lot of people I know pull the tube and walk away. Well, you've just removed their airway. I mean, they have a trachea, but if there's any kind of collapse or regurgitation, I always watch for a good 5 minutes and make sure the respiratory rate stays about the same. But the big thing I'm looking for is effort. Are they breathing harder, or are they abdominal breathing? So if I see an increase in effort and I want to get a heart rate, I want to like make sure everything is okay. So you really need to stay with the patient, monitor respiration and effort for a good 5 minutes. And then what I meant by what do you do before you turn the patient, I meant when they're asleep. Like when you guys are going to do dentals, you're going to have them in right lateral, and then you're going to have to turn them to left lateral. You always want to disconnect the endotracheal tube from the breathing system, because if you end up twisting them with everything connected, you're going to twist the tube in the trachea, and it can cause a tear. It can cause a hole. We had a case of that at Purdue that had a dental in practice and then got sent to us on emergency, and we had to take it to surgery to repair the tear. It had a dental that day. It started like puffing up and having a hard time breathing because all the air was going in the sub-Q tissues. It wasn't getting to the lungs. And the cat, it's called subcutaneous emphysema, where air goes under the skin. And this came from the cat having a dental that day. So always make sure I just disconnect them, flip them over, hook them back up. The other thing to remember about that, and this is very important, I see a lot of people, and this isn't necessarily a bad thing, but a lot of people will turn off the oxygen so they don't have, before they disconnect, so they don't have oxygen and anesthetic leaking. Then they hook them back up and they forgot to turn the oxygen back on. So if you turn off the oxygen and then you hook them back up, or some people turn off the vaporizer, they leave the oxygen on, and then your patient can wake up because you forget to turn the inhalant back on. So if you turn anything off before you flip them, that's probably the best thing to do, textbook wise, is to turn off the oxygen, flip them, hook them back up, turn on the oxygen. What do I do in the real world? I disconnect them and flip them. I'm not keeping them disconnected for a long period of time. There is a little bit of leakage of gas, but it's not going to be a large amount. So I'm just saying, like, I've just seen this happen. All of a sudden, patient gets light, patient starts abdominal breathing. We look over, we have no oxygen flow, or we have no inhalant on our patient. So what I wanted for 12 was what I just explained, and what I wanted for 16 is what I just explained. Now we are going to review these questions again, because now that I have everybody on here, or the majority of everybody, my plan is Monday, we will Zoom at this time. 2:25 is our time, okay? We will Zoom And then as soon as Zoom is done, I will open up the test at 3:15, 3:30, and it'll be open Monday, excuse me, talking all day. It's killing my voice, I apologize. You'll have from 3:15, 3:30 on Monday till 2:30 on Tuesday to complete the test. So I realize that it's after class time, but like I've explained, I think to everybody, it allows me to get a little more lecture, a little more review in, and it does give you some flexibility to take the test. But you have an entire, okay, I just want to make sure people, this is to benefit you, not me. I mean, it takes me longer to grade because they straggle in, but it gives you some flexibility. So I should hear 0, I can't get it done. You have from that afternoon till the next afternoon. So that evening, first thing in the morning, right before your next class, you should be able to get it done. Okay? And you'll have your regular 75-minute time frame to get it done. Okay? Okay. Let me share my screen. What I'm going to talk about now, and again, for you guys that are driving, this is going to be recorded. This is being recorded. Let me get my chat. And I just want to bring up the parts. When I sent you this Zoom, I resent you this PowerPoint. So this PowerPoint was the machine PowerPoint. This is chapter 4. But I realized, I know Zuber's having you guys do a project about the machine. So I wanted to lecture about some of these parts. Okay. You're fine. You guys that are driving and typing in, you're totally fine. I don't want anybody typing and driving and getting in an accident. You being safe is more important. But let me talk about, I left off at vaporizers when we ended last term. So you guys should have gotten a surgery sheet. It looks like it has boxes, kind of like this. And it talks about how to calculate your bag, how to calculate your oxygen flow. I think Zuber gave this to you. Okay. But a breathing system, let me talk about the purpose. The breathing system is supposed to carry your oxygen and anesthetic to the patient and have a way for exhaled gases to leave the other direction. Okay. So gases come in, and what I mean by gases is fresh oxygen and inhalant, and then exhaled gases, which are CO2, and excess inhalant with some oxygen. Now, the first system is a rebreathing system, and it literally means what it says. So in a rebreathing system, the patient is going to rebreathe or reuse their gases. They have the ability to do that. This system is used for patients 15 pounds and higher. So 15 pounds, and I can type that. £15 pounds and up. Now, there is something called a pediatric rebreather, and that is 15 to, I'm going to say, I used to say 15 to 30 pounds. In their notes in surgery, they do 15 to 25, give or take a few pounds. You're going to notice the difference in surgery. The tubing it's the same setup. It just looks a little bit different color. I think rebreather adult is blue and pediatric is green. So you'll notice though the size of the tubing is different. But rebreathing systems are also called circle systems because the gases go in a circle. So they go into the patient, out the patient, into the patient, out the patient, and that's where circle system comes from. Now, when they exhale, the soda lime or those white granules remove the CO2 from the system. So when they re-inhale, the CO2 is removed. They are re-inhaling some oxygen and recycled inhalant. And they're also getting fresh gas flow. Because when you have the oxygen on, there's always a flow of fresh gas to the patient, okay? Now, the flow through the system, do you remember on the machine, and I think I posted on your Facebook page, there is a video of me going through a machine, a setup video, and I think Zuber's giving you some too, but there's unidirectional valves, and they're typically somewhere near where the breathing system hooks up to. There's two hoses. Caitlin, the adult rebreather is the 25 pounds and up. Pediatric rebreather is the 15 to 25. Okay, so on this slide, it tells you unidirectional valve opens, the patient, gas comes to the inhalation tube, to the animal, they use the gas, they exhale through the unidirectional valve, it goes through the carbon dioxide canister, carbon dioxide is withdrawn, some of it is going to go into the reservoir bag, there's a bag hanging there, some of it is going to go through the pop-off, which is the dial on the top, and some is going to go out, the pressure manometer is right there, and some is going to go out to the scavenge. And then it starts all over again. So inhalation valve opens for inhalation, exhalation valve opens for exhalation. Now, I'm not going to cover closed rebreathing system. This is a low flow type of technique, and you would be trained on the job. It's done with the pop-off valve almost closed, and they use very low flow. It says used in large animal anesthesia. We have used it at Purdue on like pediatric patients. It's a technique to keep them warmer. And it does save on your anesthetic. The difference with a closed system is that you have a chance for excess pressure to build, so it can be dangerous. Running a closed system, you have to pay very close attention because if excess pressure builds, it could damage the lungs of your patient. So you guys are going to be running everyday practices, use semi-closed rebreathing. Now, your pop-off is all the way open, but the fact that you can close it at times is why that's why it's called a semi-closed system, is because it can be open and it can be closed, but it's always run open. The only time you close your pop-off is when you're giving your patient a breath. So when the pop-off is open, any excess gas, some goes to the bag and some goes out. If you've watched any of the videos for setting up the machine, there's an F-air canister and there's tubing that goes in the ceiling. Anything that escapes, that's going out the scavenge, that's the excess pressure. Semi-closed rebreathing is what I'm talking about. Caitlin, did I answer your question? It says, what is the adult? I just want to make sure I know what you were asking me. Sorry. Trying to drink a lot of this to be able to talk. Okay, So on this diagram, what I was just saying is fresh gas comes in through this inhalation valve. It's going to go through this inhalation tube through the Y piece where it connects to the patient. Patient's going to exhale. Exhalation valve goes through the soda lime. Somewhere on top, the soda lime, well, imagine this is my canister. Imagine this is soda lime. It has a lid. I'm getting creative. And this is a little pressure manometer on top. When you bag the patient, the pressure manometer should register pressure. And sometimes when the patient's breathing, there's a little dial that'll move. So somewhere near the soda lime canister, you're going to have your pressure manometer. In this diagram, they have it all spread out. But normally, all this stuff, the CO2, the manometer, and the scavenge are all kind of connected, very close together. Okay. So a rebreathing system has to have a gas inlet, directional valves, a rebreathing bag, carbon dioxide, air intake valve. Now the tubes themselves, I think Zuber has been doing this for you in class, or I saw her with the breathing tubes. Corrugated just means it has ridges. The reason that the tubing has ridges is to help mix the gas. So when the gas flows, it kind of creates a mixture. That's why it's corrugated tubing instead of just like a flat tube. So right here, and if you're driving, you can't look at this, don't worry, you can watch it later. Here is your breathing system. A is your inlet, inhalation valve, inhalation tube. This is the Y piece that attaches to the patient. When they exhale, it's going to come out the C, which is the exhalation valve via exhalation tube. Here is your B, is your pop off. Okay, so that's always open. You only push it when you give them a breath. And then the gases are going to go through here. And you can't see it in this picture, but after it goes through the granules, it's going to come into this bag. This E is your rebreathing bag, and that's what's going to move every time your patient takes a breath, because I told you one of the ways to monitor your patient during anesthesia is you can watch the bag move. You can count 1, 2, 3, and you can count the amount of breaths in your patient via that bag. And letter D is the pressure manometer. It tells you how much pressure is in the system. Very important, when your patient is awake, breathing on their own, this dial should always be at 0 or maybe 2 or 4. And this is in centimeters of water. So your pressure manometer, normally there isn't pressure, that much pressure generated when a patient breathes on their own. Now, let me go back a second. When you hold the pop off and give a patient a breath, you will see this gauge. If you remember in the PowerPoint, when you check the cuff, you bag the patient to 20. So what you do is you hold that button and you squeeze your bag till it goes up to the 20, then you let go, and that's how you give a patient a breath. So we don't normally ventilate higher than 20 centimeters of water. Okay, so the unidirectional valves literally do what the name says. It keeps the gas moving in one direction. Inspiratory is known as the inhalation valve. Expiratory is the exhalation valve. They open and close. One of the other ways you can monitor your patient, some machines, these are kind of noisy. So sometimes the machine you hear dink, 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 and you can actually count the respiration by hearing the valves open and close. Open, close, open, close. So you can use those to monitor the respiration, and you can use those to monitor the depth. Okay, so now the pop-off valve, okay? Sometimes they call it the exhaust valve. Most people call it the pop-off. Some people call it the APLV valve, which is adjustable pressure limiting valve. So in a book, you might hear it called that. Overflow valve. Most people call it the pop-off. It allows excess gases to leave the system, and it prevents excess pressure from building. So when the patient's breathing, have you ever heard of things go the path of least resistance? Because if something's going to flow, it's going to go the easy route. So some goes to the patient, but a lot of gas just keeps leaving the system. If you close that valve, what's going to happen is the gases go to your patient, they exhale, and they're in the bag, but they can't escape, so they keep going to your patient, but you are constantly running gas. So what's happening is that bag is going to start to build and build and build. One of the first things that you can look over, and if I see a bag that's really big, I run right over, and I'm like, what's the problem? I've told this story before, and some people maybe I've never told you guys. I was in an OR at Purdue, patient under surgery. I'm in the back of the room, and all of a sudden I hear, and the heart's going beep, 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 and I'm doing my stuff, and then it starts going beep, 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 and I'm like, oh my God, because that's the heart rate, and I'm like, what's happening? And I go over, and the rebreathing bag is like this big, and the student had earpieces in, but they were writing, left the pop-off closed. So I run over and I disconnect the patient, which is much faster than me untwisting the pop-off valve. So in an absolute emergency, the fastest thing I did was quickly disconnect. And then the heart went beep, beep. So I was like, but what was happening is the lungs were filling in the chest and they were pushing on the heart. So the heart's trying to beat and it's like beep, 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 beep. So it's compressing the blood flow. Leaving the pop-off valve can kill the patient one of two ways. If you leave it closed, it can explode the lungs, or it's going to stop the heart because it's going to compress the heart and stop the blood flow to the heart. So one is going to happen first. It's kind of like a chicken and egg. What's going to happen first? So always leave it open. Now the nice thing at school, you guys have these pop-off valves that are like a button. You push it and then it lets go. So it's like a safety. It doesn't let they have a closable pop-off valve, but when you guys bag, you use the little button. So it's a newer, but if you're working with an older machine, they don't have that. You have to close it manually and open it manually. So you just want to make sure that that you want to be able, leave that open. So here's an example. Now this pop-off valve you can see is both. It has a button that you can push, squeeze the bag, let it go, or you can close it. So this one, and right here, here's the unidirectional valves. Okay, that's what those are. Now, are there any, if you just pop in if you have a question about any of that stuff. Hang on. Hang on 1 second. Okay. You guys can still hear me. Okay. The next thing that we're going to do, sorry, this is being weird. The reservoir bag is the breathing bag. So people call it a rebreathing bag most of the time, but it is a reservoir because it holds something. So it is a good indicator. I like to look at the bag. It tells me how deep my patient is breathing. You know, if the bag is like, sometimes the patient's waking up and the bag is like going crazy. Sometimes it's barely moving. So it gives me an idea of character, because when you guys are in surgery, they are going to be under drapes. So it's going to be hard to watch their chest. So the bag is a really good thing. It confirms that your tube's in the right place. I've been fooled by that, not fooled by this, but someone told me they thought their tube was in. And I'm watching the bag and it's not moving. And I'm looking at the chest and the chest is going like this. I go, do you see how much your patient's breathing? Do you see your bag moving? So that means your tube is not in. Because if your tube was in, this would be moving. What the bag does is you can manually ventilate your patient. So you can squeeze it and give them a breath. They do range in sizes. On a non-rebreathing system, you use what's called a half-liter bag or a 500 ml bag. They go up to 30 ml bags or 30 liters. So here's an example. E right here, it says 2L, it's a 2 liter. Most clinics will have, and they only come in whole sizes after 1 liter, kind of like shoes. It goes half liter, 1 liter, 2 liter, 3 liter, 4 liter, 5 liter. That's what you use in small animal. When you get to large animal, I don't know if you can see, it's kind of dark. This picture, that's a 30 liter bag. So that's the size of 6 of these 5 liter bags. Large animal bags come in 15 liter and 30 liter. Now, on your canine chart, your drug reference chart, there is a bag size. There is a bag size calculation. So it's 30 mils times their weight in pounds. So if I had, let's say I had a 40-pound dog. So a 40-pound dog times 30 mils equals, hang on. Okay, so if I had a 40-pound dog, you take 40 pounds times 30 mils, that equals 1,200 mils. You have to convert mils to liters, which is basically moving your decimal 1, 2, 3 places. Technically, your dog needs a 1.2 liter bag. That does not exist. You have a 1 liter bag and you have a 2 liter bag. Which one do I pick? 2 liter bag. Always round up. You see, if you're watching this, I put a bunch of exclamation points there. Probably for a reason. Always round up. So again, and I will say some clinics, you may have like 2 bags. You may have a 2 liter bag and a 4 liter bag. You're probably better off rounding up, because what happens is if you use too small of a bag and your patient exhales and the bag won't expand, excess pressure is going to go backwards. Do you see what I'm saying? So what we have to do is we have to make sure our patient can breathe in and out very easily. So when they exhale, if that bag can't expand, it's going to cause excess pressure. So in and out, they're breathing from the bag. So you always want to round up. There will be this math on the test. Okay. So I will give you some bags. I will give you a weight, and you will tell me which bag you want to use for your patient. So half liter, 1, 2, 3, 4, 5 liter, 15 liter, 30 liter. And remember, the job of the bag is to hold a mixture of recycled gases and new gas. Because remember, when your patient is not breathing, you have oxygen and anesthetic flowing, right? So when your oxygen and anesthetic are flowing, it's going to go to the bag. Now, when the patient exhales, that's going to go to the bag. So in your bag is a mixture of new and recycled gases. Now, I'm passionate about all anesthesia, but manual ventilation is called bagging the patient. The reason you do it is, the main reason is to prevent atelectasis. I have people sometimes after 2 terms of anesthesia can't tell me what atelectasis means. Atelectasis is collapsed alveoli. If you remember all those little air sacs in the lung, when they collapse during anesthesia, which is somewhat normal, they're going to be compressed. And so what we do is we squeeze the bag to push them open. We recommend every 5 to 10 minutes. Sometimes you have to do more, like if the patient is waking up. But what it does is it forces those alveoli to open, and it's going to hopefully keep our respiratory rate normal, but it's going to prevent atelectasis. Now, let me mention something. Bagging the patient is also known as IPPV, because you might see those terms on the board exam. It's in your book. It means intermittently you're positively ventilating the patient. When a patient breathes on their own, they're passively ventilating. When we breathe for them, we are positively putting pressure in the lungs. When you do it intermittently, that is what that is. If I do something called oh my gosh. When we put an animal on a ventilator, and I will talk about that with horses because you always use a ventilator on a horse. That's continuous or controlled positive pressure ventilation. That means that animal is not breathing on their own. We are controlling it with a ventilator. What you are doing, and then the ventilator takes the place of the bag. You hook up the ventilator where the bag hooks up, because the ventilator squeezes on a timed interval and gives the positive pressure to the patient. Okay. Okay. So back to carbon dioxide canister that holds the granules. There are some different chemicals. Is calcium hydroxide is the primary chemical that I want you to know. The granules react to carbon dioxide. They can form calcium carbonate. Calcium carbonate can form heat and water. That chemical, if your carbon dioxide gets depleted and overused, that can become toxic or irritating to the lungs. So one of the reasons we change soda lime is, well, to make sure it's working, but to also make sure we don't get a buildup of that chemical. Now, this is an important picture. You've got the granules, they are white. When an animal exhales and they react, most of the granules turn purple. You can see at the top here, they're purple. When your soda lime is about 75% purple, you need to change it. Now, all canisters, kind of what people do in practice, is whenever somebody changes this, we usually put a piece of tape and we write the date and our initials. Normally, there's a lot of different things I've read in the books. Most practices change this once a month. But if you, right, they need to be, that's what I'm saying. They need to be changed once a month or every 30 days. You see what I'm saying, Caitlin? But let me finish what I was going to say. So say I have a Great Dane on this machine. Say, Caitlin, you changed it last week, and I work with you, and you changed it last week. But then I have a Great Dane on this machine, and all of a sudden I notice these are 3/4 purple. I should change that because they do go back to white. So they do change back to white. They don't stay purple. So what happens is, if you notice they're purple, it's best if you just go ahead and change it, even if they're not due to be changed for like 3 more weeks. So I will say in the book, it'll go through equations and hours of use, but like in layman's terms, if they're 75% purple while you're using it, when you're done, like finish your procedure, when you're done, you should change those granules or change them once a month. Those are the does that make sense, Caitlin? Am I saying something different than Zuber? I want to make sure. Okay, good. But no, I'm glad you brought that up because I want to make sure everyone knows they will look purple and then they're going to go back to normal. They're going to go back to white. So unfortunately, they don't stay purple. The other way you can tell, I'll just say really quick, if you can tell they're expired, when you first open a package, they're wet and crumbly. When they become exhausted, they are hard and dry. My final exam in school, I had an instructor with a practical and he had 2 cups and we had to feel them and tell him which one was new and which one was used just by looking at it and feeling it. So now most of the time you just go by the date or the color, but you can feel it and it will tell you if it's used or not. Okay. Used is hard and dry. If it's harder and drier, when you open it, it's nice and think about feta cheese. I know this is kind of weird, but how feta cheese kind of crumbles, gets those little crumbles. Maybe you don't like feta cheese, but it'd be kind of soft and crumbly like a crumbly cheese. Or they're real hard and kind of like little rocks. That's kind of the difference. The pressure manometer is telling you how much pressure is in the breathing system and in the machine itself. And it is measured in centimeters of water, not kPa, not millimeters of mercury. Centimeters of water is most machines that I've worked with. You look at this when you manually ventilate the patient to make sure you don't over ventilate. And it is supposed to be 20 centimeters of water. So if you look in this picture, this guy is pushing the button, he's squeezing the bag, and he's watching the manometer go to 20 centimeters of water, and then he lets it go. And that's how you give a breath. Now, I also want to tell you guys, clinically, I've seen some people hold the button and they squeeze the bag real slow and they watch and they hold it and then they let it go. That's the equivalent of you going, I mean, no, but you want to just go, okay? So you want to squeeze and let go like you would take a breath. So I know when Jory, Miss Wood, when she was in surgery, she told the students, take a deep breath with your patient. First of all, it's good for you because it decreases your stress. But then it helps you see how long you should hold the breath. It's like that normal IE ratio, 1 to 2 or 1 to 3. So you never hold it, wait. It's like squeeze, let go. 20, let go. 20, yes, you only go to 20. And when a patient is breathing on their own, the dial moves very, very little because you have an open pop-off. So there shouldn't be much pressure when a patient is breathing. So the only time I really check the gauge is if my bag is too big or I'm breathing for my patient, or like when you check the machine in the morning. Air intake valve, there's a valve by the machine. Sometimes it's near the top of the exhalation valve, but say for example, the oxygen was off and your patient was on a machine and couldn't get oxygen. In an emergency, the air intake valve will let the patient pull in room air to the machine. This is in different places on every machine, but it's supposed to be somewhere near your inhalation valve, near your breathing system. But it's kind of an emergency. So it'd be like, you see right here, air intake valve, some people call it, it's the negative pressure relief valve. So again, if you turned off your machine by accident or you ran out of oxygen and your patient went to inhale, they could pull air through here as an emergency. That's what it's for. Real quick, I know we're supposed to be done. Breathing tubes are corrugated. That means, and let me show you a picture. This picture, because I'm almost done, is what I want to get to. This letters A and B, well, A is a large animal. No, that's not a large animal. There are different types of breathing systems. I like the ones that are clear. I don't like these black tubes because I can't see any condensation. You can't see any breathing, but they are corrugated to mix the gases. This is an adult Y piece. B is an adult or is a pediatric Y piece. You can see the different diameter. Letter C is what you guys use at school. Letter C is called a It's called a coaxial rebreathing system. Coaxial means a tube within a tube. The inhalation tubing is the blue tube on the inside. The exhalation tubing is the exhaled, where the exhaled gases go around the blue tube. The benefit to this tubing is then when an animal exhales, it will hopefully keep the inhaled gases warm, because exhaled gases produce condensation and heat. So that is the benefit of coaxial tubing, is for that. Now, I've already gone over your sizes, how you connect your semi-system. This non-rebreathing circuits, all I want you to know about non-rebreathers is for patients 15 pounds and under. They do not recycle gases. Let me show you. I'm going through this real quick. Flow rates. Okay, I will write up a couple extra things that we'll review on Monday, but let me go back to one picture and then I'm going to end. Hang on with me once. Right here. Okay. The key, sorry, can't talk. The key difference in a non-rebreathing system is what the name says. They are not rebreathing their exhaled gases. You set this up completely different. So the inlet, there's a clear tube that goes to the patient. It hooks up near the outlet of the vaporizer. The patient inhales here. It exhales through the exhalation tube to the bag. You bypass the unidirectional valves. You bypass the soda line. That's very important. The way you get rid of CO2 in a non-rebreathing system is you run a higher oxygen flow. So when you guys calculate your oxygen flow, it's always going to be higher on a non-rebreathing system. It doesn't matter that you have a smaller patient. The higher oxygen flow is because you have to get rid of CO2. What happens is the animal exhales and the new gas comes in and pushes out the CO2. Okay? So I'm going to stop there, but the big thing is on a non-rebreather system, you bypass the pressure manometer, you bypass the soda line, you bypass the unidirectional valves. So the flow of gases is controlled by the amount of flow coming from the machine. That's the only way that you control it. So it's a higher oxygen flow for 15 pounds and under. Okay, so my plan is if you have questions over the weekend, those three things, what did I just say? Oh wait, yes. I'm typing something. Okay, some very important things I just wrote. So I know you're itching to go. I got to get you out of here. But the non-rebreathing 15 pounds and under bypasses your soda line, unidirectional valves, and your pressure manometer. So the way you get rid of CO2 is you run a higher oxygen flow. It pushes the CO2 out the scavenge system. Now at school, Vetomac, we ordered some, there are these little pressure manometers that are like a little piece of plastic, and it hooks up between the bag and the little valve. So I've never used that before until I came to the school. So it used to be when I would squeeze a non-rebreathing bag, I just had to guess. I wouldn't like crank it, but I'd watch my cat's chest go like, I'm like, okay, that's enough. It was just kind of by feel. But now you guys at school will have these little pressure gauges that can monitor, and you want to go to 20 as well. So it's the same theory. You never go above 20, but it's just a different place. Instead of having the pressure manometer on the machine, it's right by your bag when you squeeze it. Okay, is there anything else I can answer? Sorry that had to be so quick. All of your oxygen flow rates, bag size is all in this stuff that I believe Zuber gave you, okay? But I will have calculating a bag on the test, which I gave you an example in the chat. I talked about the 9-rebreather in the chat. Think about any questions you have over the weekend. We will meet Monday at 2:25 via Zoom. I can review this stuff that I went over. I can review the homework, canine feline, and then the quiz will be open right after that. Okay? I will get into the discussion board here this weekend and the homeworks to look at. I'm I'm going to try to look at some tonight, but we have to go somewhere this evening. So I'm going to try to look at some, but I will get it looked at. If you have questions, contact me. Anything else? Yes, I mean, if somebody has to go, I'm still getting a few questions. If you have to bop out, feel free to go. If you want to stick around and listen to me, you can do that too. So, Caitlin, so when you go to bag the patient, where there was a picture of that. Okay, so on this picture, Caitlin, if you can see it, so what you go to do, normally your patient's just breathing, chilling, doing whatever, gauge barely moves. When it's time to give a breath, what you're going to do is you're going to push the button on your pop-off valve, which is usually near the inhalation valve, and then you're going to squeeze your bag and you're going to watch the gauge, and it's going to go to 20. And then you're going to, and you want to just squeeze. What I say is you breathe with the patient. When you squeeze the bag, you inhale. So go. Okay. Now, usually, and this is something I should have mentioned during the lecture, I like to keep this bag about half full. I don't like it. You don't want a flat bag. That means there's nothing in your reservoir bag. And when your patient goes to inhale, it's like it's stuck. So I like to keep the bag at least half full. You don't want it too full because when they go to exhale, there's excess pressure. So when I hold the pop off, sometimes I have to hold it and let the bag fill up before I can squeeze it. Because sometimes there isn't enough in the bag, but you don't want a flat bag and you don't want it like super, super big. Does that answer your, yeah, is what? So, Caitlin, when you're bagging them, they're not breathing. So typically, so I'll give you an example. A lot of patients under anesthesia might be breathing 8 to 10 times a minute. Okay, so you are usually bagging them in between when they are not breathing. Does that make sense? So right now, if I wasn't breathing and you gave me a breath, you would force my lungs to expand when you squeeze the bag, and then my lungs would compress when you let the bag go. So I try to give the patient a breath in between their breaths. Does that make sense? Okay, now I will tell you, I have had sometimes patients that are getting light and they're kind of going, what I try to do, it's a timing thing. Sometimes I have to breathe for them while they're breathing, but I try to squeeze it as they're inhaling. Sometimes they fight against me, and it's okay a few times, but I generally either time it in between when they're breathing, but if they're breathing rapidly, then I just try to do it as they go to inhale, I squeeze. And it's okay if you feel them exhale against you, it's not going to hurt them. Sometimes they fight bagging. Sometimes when a patient's light, they can fight it a little bit. I just have to try to get the timing with them breathing. But when you do the normal every 5 to 10 minute breath, like on a normal patient, you're going to be doing it usually when they're not breathing. So thanks for asking that, because it's something I take for granted that I do every day. But yes, if you've never done it before, that's how you time it. Time it in between when they are breathing. And I will say some of the newer recommendations is only to do it once every 10 minutes. There is a lot of people, I wouldn't say there's a lot of controversy about this. I've heard people say, we don't need to bag them at all. I was taught I bag usually more than most people. But as long as you're doing it once every 5 to 10 minutes, It's also kind of based on your CO2. Remember, if your CO2 is high, the only way to get rid of CO2 is to bag them. So you may have to bag them more, but if they have a nice normal CO2, you might be fine. So it just kind of depends. Okay, thanks, Michaela. You have a good weekend. You too. So hopefully, hopefully that answered some questions. But thanks for asking that. You're welcome. Sorry, my voice is about shot, so I keep chugging this to try and get through the lecture. So I keep, sorry. Okay, well, if there's no more questions, I'll convert this and get it posted and sent out to everybody. And if you think of something about the homework or for the test, just email me. I'll be checking email tonight and through the weekend, and then we'll just meet on Monday. All right. All right. You guys have a good one. The homework was the 6th. Yes. Oh, hang on. If you're still looking at me, yes, it was these 16 questions. And then you had to answer the discussion board, but this was the homework sheet that I sent. This homework sheet was due at the beginning of class. The discussion board was due at noon today. So if you sent it last night, you're totally fine. I got a bunch last night. I got some this morning. I got some 5 minutes before class. So they kind of straggled in, which is fine. All righty. Yeah, I'm going to try to get looking at these soon. You're fine, and I'm very sorry. I'm very sorry about your grandpa. That was a lot to go through. So whatever you need, Caitlin, just keep asking me. Because starting a new term, going through that new schedule, that's a lot to balance. So, that's a lot going on. So no worries here. You know, this schedule is, it's extra crazy this term because of how we had to do RAD. Still have my sticker on. How we had to do RAD 2. That's what kind of threw everything. Well, that makes it worse. I mean, some people say, do you want it to go that way? Do you want it to be drawn out? Yeah, it's never good. So I'm really sorry. It's never good. So whatever you need to get caught up or help with, just definitely let us know. Because I know this schedule is crazy for you guys. Like, I've never done a schedule like this before in the 3 years I taught here. So this is a very unique schedule. So everyone's trying to balance. Yeah. Well, I'm thinking of you. So, okay. Well, you take care. If you need anything, Caitlin, just let me know. And I will get this converted here hopefully shortly and emailed out shortly. Okay. Yes, you have a good weekend. And just let me know if you need anything. Take care. Okay. Bye.